you'll need to transport your patient on oxygen, and then the airboat can come along to wherever you're going to land. Okay. So the second thing is that the RTs will set it up.
It will run on battery though?
No, there's no battery. It needs to be plugged in.
Okay, so let's say you have to transport.
You have to use, if the patient is on oxygen, then you have to use oxygen. If it's for worker breathing, then we have to accept some worker breathing. We'll probably put them on oxygen to
So just the regular oxygen is what you're saying?
Correct.
Okay.
There's no battery.
Okay.
Yeah.
But if we unplug it, I know there's no battery. Do we have to set it up again? Like
Yeah.
unplug it
Well, no. If you unplug it,
Yeah.
it gives you this noise
Yeah.
saying, "Hey, we lost power." So in a power outage, the same will happen.
Yeah.
It alerts you to saying it's not functioning. Okay. Okay. So I'm gonna plug it back in. Go through the startup, and it will turn on to the previous settings.
Okay.
Okay. So the RTs will come and set it up. We're going to insert the humidifier pot. We attach our circuit, and it's the same circuit for all patients, adult, pediatric, baby. What's different is the interface.
Yeah.
So the circuit comes like this. The interface comes separate. We have, the different sizes and different colored boxes with different squiggly shapes. They're sized according to the size of the baby or the child, so according to the size of the nares and flow rate. So we look at both in determining interface size. So I plug in my interface, and then we're going to set up our Airvo. So what do we use Airvo for?
Respiratory increased worker breathing that is not for oxygenation issue that cannot be maintained.
Right, yeah. So for the pediatric population, like apparently there's someone with the pneumonia, so worker breathing and oxygenation, so both probably, right? They were on a little bit of oxygen, they needed more, they're working hard. We're going to use Airvo. So Airvo is basically providing a high flow nasal cannula. And right now I have it set quite high. You can feel it coming out, right? It's like, whew, that's like 18 liters a minute, right?
It's like CPAP, nasal CPAP.
Yeah. So it's high flow. And how can we do high flow? We can do high flow because if we were to do this just with standard cannula, 18 liters of oxygen coming out, you're like, it's going to be drying, it's going to be cold. So this is heated and humidified. So it's providing that the humidity and warmth that our nasal passages provide is coming from here and supplementing it so that we don't have nasal breakdown with the high flow. And the cannula size is big, so most of what the person is going to be breathing, the pediatric patient in this case, is going to be coming from these cannula, okay? So, how do we set it up? Well, we look at our patient, worker breathing, and oxygenation. So, in this case right now, I come and look around. You'll want to see the screen. Right now I have it set for 18 liters a minute. So how are we choosing our flow rate? We're going to go based on weight, 1.5 to 2 liters per minute per kilo. So if our average is like, if this child is really working hard, I'm not going to goof around at the lower flows. I'll probably just go to 2 and see. Let's see if 2 helps. Because if 2 doesn't help, then we need to move on to the next measure, right? So I'm going to go to 2 liters per minute per kilo. So if we have a 9 kilo child, we're going on 18 liters per minute, okay? So 18 liters a minute is going into their nares, and this is going to be supplementing and aiding their work of breath. Because if we didn't have this, all of what they're breathing, they have to work so hard to get it. All their accessory muscles are being pulled into play. So this is giving them that supplement so they can go, oh God, I don't have to breathe so hard now because this is giving me what I need, okay? How are we gonna set oxygen?
Based on their O2 sat.
Exactly, yeah. So you're gonna titrate oxygen according to saturation, whatever it is your order is, like 94 and above, let's say, okay? So if they're satting 88% on room air, I'm going to go up on my oxygen.
Right.
The way the Airvo works is when you set your flow, it will always deliver that flow.
Yes.
The machine pulls in room air from here. It's a little compressor and sends out 18 liters per minute.
Right.
When I add oxygen into my Airvo, the Airvo adjusts to deliver less air because now we're delivering some oxygen, okay? So watch what happens when I turn on my oxygen to my percent and my flow rate, okay? So if they're desatting, let's say I go to 2 liters per minute.
Okay.
They're desatting to 88 on room air, so I'm going to 2. Already I'm up to 27. 18 liters per minute still. So that doesn't change.
Yeah.
The Airvo just adjusts how it delivers it. So it delivers a little bit less room air because we've given some oxygen. Okay? If I go up, I'm still only at 90. Let's say I'm going up to, what is this? 6.
Give you 48%.
Yeah, I'm being dramatic here in my, right? So look how much oxygen we're giving. So 48%, yet still 18 liters a minute. This hasn't changed. It still comes up heated and humidified because it's going through the Airvo. Make sense?
Yes.
Okay, so if my baby or my child was on, your pediatric patient was on, it's 2 liters per minute per kilo, and you're following the RTs are going up on our settings, and now you're at 45%. That's when my red flags would be going off, is when we hit 40 and they're still like not doing great, they're still just at their threshold or just below their oxygen threshold, then I would be thinking, okay, maybe this isn't working. After troubleshooting to make sure that prongs are in the nose properly, this is connected, this is connected, so making sure everything is on and in proper function. If I'm still needing 40 to 50+% oxygen, then I'm thinking, okay, we need to escalate.
So I know we have the blender up here. Would you connect it to the blender, or you connect it directly to the O2 source?
Great question. Directly to the O2 source.
Okay.
Because then I don't know, right? Then it's like you're giving a blend of a blend, a blend of a blend of a blend.
Even when you turn it on to like 100%, it still won't work?
Yes, when you turn it on to 100%, it will. But to rule out, to eliminate room for error, I'm going straight to an oxygen source. Okay. Okay. So an alarm came up here, and let's see if it'll happen again. The screen goes yellow and it says water empty, I think. So one of the most common alarms is that this is empty because the bag ran dry. So normally when I'm getting this is my teaching circuit, so I don't want to spike the bag.
Okay.
But normally, of course, when we set it up, we spike the bag. Water fills up the chamber, and that's how it gets humidified, heated and humidified.
Okay.
If for some reason the water bag runs dry, this runs dry, it senses it and it'll alarm. It'll be yellow on the screen, and it'll make that sort of annoying beep.
And we can just hang a new bag?
Hang a new bag,
Okay.
exactly. Yep. Another common cause for an alarm is if there's something kinked or disconnected.
Yes.
And it's really smart. It says so right here. So you just hear that going beeping and you go, okay, look to see what it is.
Yeah.
I had this on, and this must be, even though it's, maybe I got whatever in my teaching, it's calling it, there's a leak.
Oh, check for leak.
Yeah.
Okay. Maybe there's a hole in there somewhere. Yeah.
So that's what that looks like. So you just go through your circuit. Does everything look okay? You're calling the RT. If need be, the RT will come through, troubleshoot it, and maybe there's a break in the circuit or something. This tubing here on the interface is anti-kink tubing. That's why it looks the way it looks.
Yeah.
So you can't crush it, with bedside rails or anything like that.
Yeah.
Okay, with the kid rolling over and sleeping, it won't be crushed.
So what's the max? I know you say 1.5 to 2. 2 would be the max that you can give.
That's what our protocol says.
Okay.
Now, if when we're in consultation with the pediatrics or folks from sick kids and they say, you know what, I think it's going to work, try 2.5, then I would try 2.5, right?
Okay.
If someone gave me that order.
Okay.
But for now, the way it stands is that we're looking at 2 liters per minute
Now,
per kilo.
I know we go according to weight.
Uh-huh.
What if you have somebody that weighs like a teenager that weighs like 100 kilogram, for example?
Yeah.
Then what is
like
your
an
max
adult?
setting, like an adult?
Yeah, so it'll probably be actually around the same, but if their body is like an adult's, then I would likely treat them more like an adult. And with an adult, we go up to 60 liters per
60,
minute.
that would be the max.
Yeah,
All right. Okay.
good questions. Great questions. Okay, so in terms of titrating, we titrate oxygen down first, and then
The flow.
flow, but I wouldn't go much below 1.5 liters per minute. If their work of breathing has improved greatly because their disease process has improved, then if they're good on, like if they look really great on 2 and they look really great on 1.5, then they should be able to come off, right? And if they can't tolerate off, then they need it. It's
Okay.
like on or off. There's not a lot of down on the flow. There is on the oxygen. I certainly would titrate down the oxygen.
And one more question. Let's say if you have a patient, like for example him, he's COVID negative.
Uh-huh.
Do you still do HEMP for him and put him on negative blood pressure and N95?
Yeah, we're still treating all ergo
That's what I told
as
Carla.
AGMP.
That's what I told Carla, and she said I'm pretty sure you still have to do
At
that.
the moment, all ergos are run in rooms that can offer negative pressure.
Yes, that's what I
Yeah.
told her. I said,
So
you
on
have to do
A3,
it.
you know how they converted A3 into our COVID ward,
Yeah.
they added standalone HEPA filters to make it a negative pressure
Okay.
room. Okay.
Okay, great.